So now we will try to understand the ways how we analyze coronary artery disease and how we report it on cardiac CT. Okay, so there are 2009 guidelines from the SCCT about interpretation and reporting of the cardiac CT, and I would recommend you reading these guidelines. They're quite useful. And then lately, just this year, they have published what they call CAD or CAD REDS reporting method. So it's CAD is coronary artery disease, and RAD stands for reporting and data system. So it's a reporting and data system for coronary artery disease based on CT angiography. The way the coronary arteries are divided into different segments is similar to the AHA way of dividing coronary arteries into segments on invasive angiography, with some very minor differences. So this document actually gives those differences in detail, but I went through them with you in the anatomy talk yesterday. The way one classifies different degrees of stenosis on CT angiography is can be both qualitative or could be quantitative. In qualitative grading, we can say it's normal, minimal, mild, moderate, severe, which we all do in routine practice. Normal will be if you see no plaque whatsoever in the coronary arteries. You will say the plaque is causing minimal stenosis when you think it's just minimally or impacting on the lumen of the coronary artery. Mild when you think there is plaque, not minimal, but it's not causing significant obstruction. Moderate when you are not sure it's mild or moderate or severe, then you will call it moderate. And severe is when it looks pretty sure that it's going to be severe stenosis. So this is totally based on your visual estimation of the degree of stenosis on the CT angiography. And then there is quantitative method of classifying stenosis. So minimal is less than 25%, mild is 25 to 49%, moderate is 50 to 69%, and severe is more than 70%. So pretty much similar to what you would use in invasive angiography. Now the CAD RED classification is similarly based on this quantitative classification, and they are giving the numbers 0 to 5 for different degree of stenosis. So grade 3 is moderate stenosis, and 4 is severe stenosis. 4A is single vessel disease, while B is 2 or 3 vessel disease with or without left main. So a significant disease where you would want the patient to have a catheter angiogram. And then they recommend, they also say that you recommend based on the classification, the grade of stenosis, you recommend further investigation or further preventive therapy. On invasive angiogram, we have tools to quantify the degree of stenosis, QCA methods, but they're, I think, rarely used in practice. So most of the time, as cardiologists, you would visually try to quantify the degree of stenosis. And we know the limitations of single projections, particularly on any technique. Most of the plaques we have in the coronary arteries are eccentric, so you can underestimate the degree of stenosis or overestimate the degree of stenosis. Techniques like CT angiography allow us to look at the lumen of the artery and the plaque along the 360 degrees of the vessel wall. So all along the wall we can see the plaque distribution, and then we can estimate the degree of stenosis, just like we can do on IVUS in a similar manner. So in this example here, you can see the plaque itself. So you have calcium in the plaque, you have the soft element in the plaque. So this is a mixed plaque, and you can see the lumen filled with contrast. And you can see this is an eccentric plaque. And you can quantify the degree of stenosis on in such plaques by either measuring the minimal diameter at the point of plaque and referencing it to the proximal normal lumen, or you can do area quantification like this. So minimal luminal diameter or minimal luminal area. And there's a formula for percentage stenosis quantification. So in this formula, L is the lesion, so the diameter or the area at this point, and R is the reference diameter or reference area. And on advanced CT softwares like Vitria, you also have tools where you can use to actually quantify the degree of stenosis. So you can draw such tools through the proximal normal segment to the distal segment, and the software will calculate the diameter and area stenosis for us. So there are tools available to do that precisely. Now, what we normally describe the stenosis is in terms of diameter stenosis, but we can also describe on CT angiography area stenosis as well, because it has the capability of measuring the actual area of the lumen at the point where the plaque is, and also at the normal parts of the coronary artery. So how does area stenosis relates to the diameter stenosis? So here, for example, the diameter stenosis of 50% relates to 75% area stenosis. Now, this is applicable only if the stenosis is circular, if it's causing circular reduction in the lumen, so from a concentric plaque. So for eccentric plaque, this formula is not applicable. And I think there is no good formula to estimate from diameter stenosis to area stenosis if you have eccentric lumen. But normally, for the same degree of diameter stenosis, you're looking at a greater degree of area stenosis in terms of number, what it means. So the way I do it in terms of stenosis quantification, so if on CT angiography, if the lumen appears to be definitely not flow limiting, I will call it mild. So this category here, yeah. So I would not measure it. I would just visually see the lumen looks mildly stenotic compared to the proximal normal coronary artery or distal normal coronary artery, call it mild. If it looks definitely or most likely severe or flow limiting, yeah, we are only saying flow limiting in the sense possible flow limiting, because we do not know, we are not doing a functional evaluation on CT angiography. We are simply doing anatomical quantification. So if I think it's 70% or more stenosis, then I will say that's severe stenosis. When I'm not sure, yeah, so middle category, I'm not sure here, then I would call that moderate. And then just to substantiate my visual estimation, then I will use quantification in such cases, using either diameter or area tools, yeah, on the software. So otherwise, I would just visually say mild or severe. So the first thing is about quantification of degree of stenosis. The second thing is about this description of the plaque morphology. So traditionally, we classify plaques into calcified plaques, the non-calcified plaques, which are the soft plaques. So soft plaques could be either composed of lipid or fibrous tissue or a mixture of both, or mixed plaques. So the SCCT document recommends not to use the word soft. They say to use the word non-calcified, because to differentiate between different densities in the soft plaque, to say this is lipid or this is fibrous can be quite difficult. So they suggest that use the word non-calcified. If there are other features in the plaque, such as ulceration or fissures or dissection, then we need to describe them as well. So we characterize the plaques in one of these three categories. And then we describe the location of the plaques. So which segment of the coronary arteries they are, and the relationship of the plaque to the ostium of the artery, to the branches of the artery, bifurcations, etc. So let's look at some examples. So in this one, you have so you have the plaque. So you have calcified calcium here. You also have non-calcified element there. Yeah. So at this point, where my blue marker is in the plaque is here, we're describing this plaque, for example, because that's what I'm showing here. So the plaque is of mixed nature. It's got calcium, focal calcifications, and there is a non-calcified element. And if you look at the lumen of the artery here, this is definitely not obstructive, not significant. And I can be also sure that this is not likely to be flow limiting. Yeah, it's not moderate either. So at this point here, yeah. So I will call this plaque is mixed in nature and is causing mild stenosis of less than 50%, definitely less than 50%. And this is unlikely to be flow limiting. Now at the point further down, the story is different. This could be more severe plaque stenosis here. Sorry. So let's look at another example. So in this case, the nature of the plaque is pure calcified plaque here. And if we now look at the lumen, so lumen is this one filled with contrast. So this again, so it's again causing less than 50% luminous stenosis. Or you can even further grade less than 50% as less than 25% or between 25 to 49%. So this is again mild stenosis. So next example here. So we have a plaque here with some calcium, soft calcium, and predominantly soft. So we get on this long axis view, we again see a mixed plaque. I'm just going to have some water. And if you look at the lumen carefully, so this plaque, I would say, is causing probably moderate degree of stenosis here. So you have to compare with the artery proximally as well. It's just not the impression that we see from the that particular point where the plaque is, but also compare with the artery proximally. Okay, so that's next example. So lots of calcification in this plaque, diffuse plaque, but there's also a non-calcified element forming a cap around the inner aspect of the calcified plaque, and the lumen here with contrast is very small. So this is a mixed plaque, or you can say a predominantly calcified plaque with a non-calcified element, but causing more than 70% luminal stenosis. So this is a severe stenosis. And this last example, so there's no calcium here. This is just a non-calcified plaque, and there is complete loss of lumen, complete loss of contrast in the plaque. So this is likely to be occlusive disease. So sometimes, occasionally, there could be, if you are doing a selective injection of the coronary artery, and it may show a small channel through the what appears to be an occlusive segment on CT angiography. So CT is not so good at picking up collaterals unless they are large collaterals. So we don't see them in chronic total occlusions so clearly on CT, but they may be seen on the catheter angiogram. Now, there are, so besides classifying the plaques as calcified, mixed, and non-calcified, there are certain high-risk features that should be described, which one can appreciate on CT angiography as well. So from the IVUS studies, from the post-mortem studies of patients dying of MI, we know that some of the features of high-risk or vulnerable plaque are presence of thin fibrous cap of less than 65 microns, presence of large lipid core, necrotic core in the center of the plaque, presence of external remodeling in the coronary artery, and spotty calcification. Calcifications have also been described as feature of high-risk plaque. So how do these features look on CT? So thin fibrous cap is something we cannot see on CT. Anybody who claims they can, probably they have got very good eyes they can see, but it's beyond the resolution of CT to look at something thinner than 65 microns. But we can look at other features. So in this example, so first feature is low attenuation plaque. And low attenuation is described differently by different studies. I think most people agree that if the plaque is less than 50 Hounsfield units, then you can classify that as a low attenuation plaque. And that's how it looks like. So in this example, this is a low attenuation or low density plaque here. So if the density you measure is less than 50, then you call that. Now, a sign that's been described called napkin ring sign. So this is basically this sign, this appearance here, where you have a low attenuation plaque towards the lumen of the contrast, and you have higher density, a higher attenuation component surrounding it. So this is called the napkin ring sign. So this is a lipid core, and this is more of a fibrous part component of the plaque. Okay. And this has been validated on histological studies as well, or compared with IVUS, etc. Then in this study, they tried to classify based on CT angiography data in CT angiograms performed in hearts taken from postmortems. Basically, they injected contrast in patients dying of MI and injected contrast and did CT angiograms in these hearts. And they tried to classify plaques into 3 different categories apart from the traditional classification. So the non-calcified plaques, they found them in 3 categories: homogeneous plaque, then heterogeneous, where you have both low areas of low attenuation and high attenuation, and then patients with napkin ring sign plaque. And they thought this perhaps is the most prevalent in these patients, the napkin ring sign plaque. And as I said here, plaques with napkin ring sign represented histologically advanced lesions. So this is another example of a correlation between CT angiography with IVUS, and this is a napkin ring sign in this plaque. And the authors said that on IVUS, the napkin ring sign, which on CT appears more like has a speckled pattern on IVUS. And this is the example of positive remodeling. So where you see the artery in the region of the plaque is expanded compared to the artery proximally and distally. So one can measure the maximum diameter of the artery from the external lamina to external lamina, and compare with the diameter of the artery where there is no plaque. And if the ratio is more than 1.1, then that artery is supposed to, that particular segment is supposed to have been externally or positively remodeled. And then lastly, the spotty calcification. So calcium of the size of up to 3 millimeter or less, they are supposed to be called spotty calcification, and their presence in non-calcified plaques are also an indicator of vulnerability of these plaques. So again, an example here, this is napkin ring sign along with the spotty calcium. So there have been some studies now which are showing the prognostic value of these high-risk feature on coronary CT angiography. And in this latest study published just, I think, last month, and which shows in 1,500 patients with low to intermediate risk undergoing coronary CT angiography, followed for almost 8 years. And you can see some of the signs. The best sign in terms of prognosis was napkin ring sign. So hazard ratio of 7. Then your low attenuation plaque of less than 60, hazard ratio of 4.5, and spotty calcification 2.6. Now they didn't find remodeling index to be prognostically significant. This is a lot of work. Somebody trying to analyze all these plaques in so detail, I must say, is a lot of work. So this is another study from Japan, 3,000 patients followed up for 4 years. And here you can see the presence of high-risk features in the plaques, irrespective of degree of stenosis, was predictive of outcome. Okay. So, but there was an accompanying editorial by Valentin Fuster, whom some of you may know is one of the world's authority on vulnerable imaging of vulnerable plaques. And he said that this is probably a myth. And it is a myth because he says it may be more important to manage patients based on total atherosclerotic burden rather than trying to hunt for individual vulnerable plaques. And the reason he says that is that individual plaques can have high-risk features, vulnerable features, but most of these plaques will become thick cap fibroathromas subsequently, because in all our coronary arteries, the plaques are undergoing transition from different stages, different types, vulnerable to non-vulnerable, etc., etc. So only very few plaques stay as thin cap. Most of them will become, normal stable plaques. And also the data that we have from different studies, which are showing that just presence of extensive non-obstructive plaque itself is prognostically important. So it is the overall atheroma burden in coronary arteries that is probably more important from point of view of prognosis than trying to hunt for individual high-risk plaques. So then the question comes, we know there's a very simple technique called calcium score, which allows us to very crudely quantify the plaque burden in the coronary arteries. But some people have tried to quantify the plaque burden on CT angiography as well. And there are three methods to do it. And the first method is called segment involvement score, second is segment stenosis score, and third is CT Lehman score. Have you heard of these methods? No. Okay, so let's go through them. So segment involvement score is the simplest score. So it basically is number of segments with plaques. And the score can vary from 0 to 15 because there are 15 segments in the coronary arteries, 15 or 16 segments. So if you have 3 segments, the plaques are in, so the score will be 3. It's very simple. So it doesn't depend upon the location where the plaque is. There's no importance of that in this particular score. So in this example I have drawn here, so 3 plaques here. The score will be 3 just because there are 3 plaques. Score of 3, SSI of 3. Now second scoring method is called segment stenosis score. Now in this, the number of segments with plaque are weighted for the stenosis severity. So if you have the plaque is causing less than 30% stenosis, then give a score of 0, point of 0, and similarly increasing number based on degree of stenosis. And so you multiply, so for example, in this plaque, this is plaque is causing 40% stenosis, yeah, in left main, it doesn't matter the location. So this plaque will have a score of, it will come in this category, so 1. This plaque will have a score of 3, 1 plus 3, 4, and this will have a score of 2. So that will make it score of 6. Yeah. So you can have scores up to 45 with this particular method, score of 6. So this takes into account the number of plaques and takes into account the degree of stenosis, but is not taking into account the location of the plaque. So the next one takes into account of that. This is called, so this is the Lehman score. So Lehman score looks at the plaque, number of plaques, location of plaque based on dominance. The type of plaque, whether it's calcified or non-calcified, and it also takes into account the degree of stenosis. So this is more becoming complex now, isn't it, in terms of quantification. So what you do here, and this is described in some of these articles very well. So this is a chart here. So every case you have to go through this chart, this imaging. So let's do this for this particular case. So here assume that all plaques are calcified, to keep it simple. So if you have this plaque in left main, so left means plaques are given the highest score because of their worst prognostic value. So if you look at left main here, it is, where is left main here? Left main here. So left main is given a score of 5 in the right dominant artery and given a score of 6 in the left dominant artery. So this would have, so here the score will be 5 times 0.6, and 0.6 is a score for non-obstructive CAD. So this plaque is 40% stenosis, so less than 50%. So 5 times 0.6. In LAD, the plaque is 100% stenosis, proximal LAD, and the score for proximal LAD is 3.5. So you multiply 3.5 by obstructive plaque number, which is 1, and RCA mid-segment has a score of 1 times 1 because it's more than 50% stenosis. So that way you get a score of 7.5. So in this method, any score of more than 5 is supposed to have an adverse prognosis. So this is obviously a most comprehensive method in terms of assessing the plaque burden on coronary CT angiography. Okay. So now this particular study had tried to use all these 3 methods in 1,200 patients and followed for 52 months. So what they found was that a Lehman score of more than 5 was significant here. So irrespective whether the stenosis was less than 50% or more than 50%. You can see there. So all the scores have prognostic value, But the best prognostic value you see is from the Lehman's score, which is obvious because it is looking at the location of the plaque as well, and also the nature of plaque, whether it is purely calcified or it is non-calcified or partially calcified plaque. So that is about, so we have covered how to quantify stenosis, how to characterize plaque in terms of calcified, non-calcified mixed, how to identify the high-risk features, and then how do we score the plaque burden on CT angiography. Now, we'll go through a bit about the FFR. So, in terms of the way we go about imaging patients with stable chest pain, so you can go down anatomical pathway starting from cardiac CT, or you could go down a functional pathway starting from a stress imaging technique. So if you went down anatomical pathway, then if you see moderate stenosis on CT angiography, then that's where the stress imaging is most valuable. Obviously, you can do stress imaging in patients with severe stenosis as well, just to make sure that this is causing ischemia, because we know several cases where anatomically the stenosis may look severe, but functionally it may not be. So there are various non-invasive techniques we have to assess ischemia, and Andrew has gone through them early in the morning, so I will skip this. Invisively, now we have this tool called Invasive FFR. So for those of you who are not cardiologists, so FFR is fractional flow reserve. So the way it's done is by introducing a pressure wire into the coronary artery through the stenosis, and in assessing the pressure distal to the stenosis, comparing to the pressure in the aortic root proximally under maximal hyperemia by injecting adenosine either into the coronary artery or intravenously. And normally the FFR should be 1, but if it is less than 0.8, then it is supposed to be functionally, that stenosis is supposed to be functionally significant. So with different trials like deferred trial and different FAME trials, this has become now a method of choice to assess the functional significance of intermediate stenosis in the cath lab. Now, some of you might have heard that we can do a non-invasive FFR on CT angiography as well now. So there are two methods on CT that we can assess the ischemia. So one is the CT FFR, and the other technique is the stress perfusion imaging, like how we do stress MRI or stress nuclear imaging. So stress perfusion imaging, one of my colleagues from Brompton is going to talk about on Thursday morning. So I'm just going to focus on CTFR here. So this is based on engineering technique from biomedical engineering called computational flow dynamics. So it's all about modeling the anatomy and deriving the functional information from the anatomy by outlining some input and output flow conditions. And it's quite complex, basically. I've tried to understand it several times, but it's very difficult. But all they require to perform this analysis is the anatomical data that we obtain from CT angiography. So same data. So there's no new data that's required for this. And they put this data through a supercomputer in a company called HeartFlow, based in Stanford, in California. So they showed in their initial studies a few years ago that this technique is clinically possible. And like in this example, patient having possibly moderate stenosis from a mixed plaque in the proximal LAD, and this is the CFD modeling from that data, and you can see patient has the FFR of 0.62 here in the distal. So they can color code the degree of pressure variation, pressure ratio variation through the artery in this manner. And they correlated like this. For example, this is invasive cath with invasive FFR of 0.65 in this example. Oops, how do I have that? Let's see, something's happening here. Okay, I had more slides on this. Let me just check. No. Okay, so I'll just speak about it. So there have been 3 or 4 trials, multi-center, comparing CTFFR with invasive FFR. And in the first trial that was done, they showed that CTFFR improves the positive predictive value compared with the positive predictive value from just standard CT angiography. Okay. So they said that it will make your diagnosis better, improve diagnosis, and reduce the number of patients going for a false positive catheter angiogram. And that study was called Discover Flow. I think you will have the slides on your in the manual. The next study they did was called the de facto study, and this was also a multi-center study in which they did not find any significant difference between the positive predictive value between CT angiography and the CTFFR. The third study they did, they found some difference. So I think it is still debatable that this technique is how much it is feasible. It is costly. It's been done only by one center, commercial center in America. But there's one study that published recently where another vendor has come up with their own software, which you can plug it in your own workstation in your hospital, and you can do it right there. So at the moment, you have to, if you want this company to do the FFR from CT, you have to upload the data on their server, and they take 24 hours and they charge you 1,200 pounds for it. So it's a very costly affair. Now, FDA has approved this technique based on the trials they have done, and they are pushing this technique here under NICE guidelines. But the BSCI has expressed serious reservations for introduction of this technique in UK. So it is costly. It is costly, no doubt. I mean, I think once it comes down to the software level where we can do it ourselves, we can try the soft technique ourselves, get an own experience. I think it will be less applicable from clinical point of view. I would say, you could get done a stress echo for 300 pounds or something like that. Why do you want to spend 1,200 pounds of taxpayers' money doing this technique? But if it is possible, if it is cost effective, then I think this technique can become very useful in clinical practice. The number of patients that we will require this technique is around maybe 15 to 20%. As I said, moderate stenosis to severe stenosis in patients with stable symptoms the prevalence is not very high. So it can be doable if in 1 in 5 patients that come through for CT angiography, you have to spend some time in doing this analysis on your software. It may be doable. Okay. So now in terms of reporting, how to report cardiac CT angiography. So you start with, yes, Gabby. Yeah. So if you have multiple lesions, basically it gives you the FFR through the whole artery. So it will calculate FFR everywhere at every point. So it will just give you that it is declining or not, the FFR at different points. These images are very beautiful, and they give you a 3D model of the coronary arteries with FFR at every point, and you can bring your cursor. Okay, you want the FFR at this point, and you just bring your cursor there. It will give you a value. This is the FFR at this point. So a lot of clever IT brain has gone into producing this technique. So I'm trying to use this technique in collaboration with Brunel University Bioengineering Department to assess the flow through the aortic valves in patients with aortic valve stenosis, and that's a very fascinating area as well. But it's a technique that has been used for years in designing racing cars, designing aeroplanes. It's the same technique that bioengineers use all the time. So it's interesting. So we start the reports by describing the indications briefly, why we are doing the scan in the first place, then describing the technique, type of ECG gating we have used, how much contrast we have given, what contrast we have given, how much beta blocker we have given, GTN, what was the heart rate of the procedure of the patient during the procedure, and what's the image quality like. So all that goes into the technique of the report, technique section of the report. Then if you've done a calcium score, you describe the calcium score in terms of its absolute value. I give the percentile only if the score is less than 100. Otherwise, score of 100 or more, I take it as a significant score or a high risk score based on the evidence we have. Then we come to the coronary angiogram. You describe the origins of the coronary arteries, the dominance. Then you describe the plaque in terms of its distribution, composition, and degree of stenosis, like how we have gone through. Then you describe the size of the cardiac chambers, the thickness of the myocardium, if it is abnormal. So I would say the cardiac chambers are normal in size. Myocardium is normal in thickness and enhancement. So you're looking at enhancement as well. Then you describe the aortic root, then parts of thoracic aorta. So we are seeing the proximal part of the ascending aorta. We are seeing the mid to distal part of the descending aorta. So describe that they are normal size. And then you describe the non-cardiac structures. So I use one sentence, which is pericardium and the surrounding lung parenchyma are unremarkable if it's a normal study. But just describes that, saying that, and then I make sure I have seen those things as well. Then if you've done retrospective gating, then you can assess the volumes of the ventricle, ejection fraction, any recent wall motion abnormality, etc., etc. So all that goes into report. So how it looks like. So reports, the conclusions of the report should be precise and clinically relevant. And you could guide, if you are a radiologist performing them, or if another cardiologist has referred you the patient, then you can guide the referring cardiologist for further management, like how the CAD REDS document is suggesting. So normally I would say if it's less than 50% stenosis, I will say no further imaging, no further investigation is required. If it's moderate stenosis, I will say do a stress imaging test. In my own hospital, we have had an agreement with our referring cardiologists from other hospitals, whereby we would offer them a stress imaging, which is stress CMR, free of any further charge in patients where we see moderate stenosis. So that's a special service that has been provided for a number of years. But number of these patients are relatively small, and they like it because they see they get a complete answer from a request, and for us we get continuous work from them, so it's good. And more than 70% stenosis, I would suggest a catheter angiogram or a stress imaging depending upon patient symptoms. So a normal conclusion would look like this. So absent coronary artery calcification representing low cardiovascular risk. So this first sentence is very important because, as I've shown you, a zero calcium score is a very marker of safe prognosis for at least 6 to 7 years. And then there is no evidence of atherosclerosis or anomaly on the angiogram. So I mentioned about anomaly only in patients, say, younger than 50 years, because after that, anomalies are relatively safe. Yeah. Reassuring study. So other type of report would be patient has a high calcium score, so high calcium score presenting increased cardiovascular risk. So I always emphasize on the risk from the calcium score itself. So, however, there is no evidence of significant luminal stenosis on the angiogram. So that second sentence is from the angiography part of the data. And third could be like this. So high coronary calcium score representing increased risk. Then there is a mixed plaque in the proximal LAD on the angiogram causing at least moderate stenosis. Stress imaging is recommended for further evaluation. And you will be grateful for a feedback. So something like this. And the last could be patient is having severe stenosis on the CT angiogram, and then you may suggest a catheter angiogram. So nowadays I suggest stress imaging or a catheter angiogram based on patient symptoms. So I don't say catheter angiogram because sometimes cardiologists may decide that probably symptoms are very iffy and patient probably just needs a stress imaging test done. And that's fine. That's overall how we try to assess, interpret, and report cardiac CT.